Welcome back. Today, we're jumping straight into a hyper-comprehensive explainer that's going to completely demystify two of the absolute heaviest high-yield topics in neurophysiology, the blood-brain barrier and the neurological mapping of language. Now, I know these topics can be notoriously tricky, but I promise you a totally zero-fluff, exhaustive deep dive here. We're going to extract every single crucial detail so thoroughly that you literally won't even need to crack open your textbook afterward. We're not skipping a single important concept. So let's just get right into mastering the brain's ultimate defense system and its most intricate communication networks.
Let's take a quick look at our structural roadmap. Section 1 covers blood-brain barrier fundamentals, followed by Section 2 on assessing and breaching it. Section 3 tackles the types of cerebral edema. Then we pivot to functional networks for Section 4 on localizing speech, Section 5 on the classic language model, and finally Section 6 on the modern dual-stream model. All right, let's get to it.
Starting off with Section 1, blood-brain barrier fundamentals. Let's dive right into the physical fortress of the central nervous system.
So looking at the foundational neurophysiology of the blood-brain barrier, if you've ever felt totally overwhelmed reading dense paragraphs like this, don't sweat it. We are going to decode every single rule, every exception, and all the clinical applications locked within it, step by step.
Okay, the absolute foundation of the blood-brain barrier, or the BBB, lies in something called zonulae occludentes. Basically, these are extremely tight junctions located specifically between cerebral capillary endothelial cells. Their main job? To restrict the passage of water-soluble substances from the blood right into the central nervous system. Now, here's an absolutely crucial distinction you cannot skip. The BBB is completely different from the blood-CSF barrier. That blood-CSF barrier is formed by tight junctions between the epithelial cells of the choroid plexus, not the capillary endothelial cells. It's a subtle but massive difference. But hey, the brain still needs fuel, right? So specialized transport systems exist to selectively allow vital molecules like water, glucose, and certain amino acids, especially the ones acting as neurotransmitter precursors, to pass right on through.
But, the BBB isn't some invincible, static brick wall. Its defenses are routinely compromised by pathological states. If a patient comes in with a brain tumor, a central nervous system infection, head trauma, a stroke, or even hepatic encephalopathy, you can absolutely bet their BBB has been disrupted. And this actually brings us to a brilliant clinical application, pharmacology. We can literally manipulate this barrier. If a clinician needs to temporarily open it up, say to reduce intracranial pressure or deliver a specific drug, they can use hypertonic mannitol. On the flip side, if the goal is to tighten the barrier up and stop small hydrophilic molecules from getting through, steroids are your go-to pharmacological tool.
Now, what about the exceptions? Because the BBB isn't universally present everywhere in the brain. There are actually specific structural zones where this barrier is completely absent, which allows the brain to directly sample and monitor the chemical makeup of the blood. These are the circumventricular organs, like the area postrema and the median eminence of the hypothalamus. It's also totally absent in the narrow hypophysis, which is your posterior pituitary, as well as the pineal gland, the choroid plexus, the tuber cinereum, and the preoptic recess. Definitely commit these regions to memory. Knowing exactly where the barrier is down is just as important as knowing where it's up.
Moving right along to Section 2, assessing and breaching the BBB. Let's look at how clinicians actually test the physical integrity of this barrier in the real world.
So if the barrier is compromised, we obviously need a way to see the leak. We've got 5 main categories of assessment tools here. For direct visual confirmation, we use visible dyes, like Evans blue or fluorescein. Now, in modern neuroimaging, picking the right agent is absolutely critical. For CT scans, we use radio-opaque dyes that contain protein-bound iodine. But if you're using an MRI, you have to switch to a paramagnetic agent, specifically protein-bound gadolinium. This takes clever advantage of heavy metals reacting to magnets to get a crystal-clear picture of the disruption. For microscopic, cellular-level assessment in research settings, horseradish peroxidase is the gold standard. And finally, radio-labeled markers like albumin and sucrose can be utilized. Honestly, knowing which modality pairs with which agent is an unskippable clinical fundamental.
Next up is Section 3, Types of Cerebral Edema. Look, when the brain sustains an injury, swelling happens. But not all swelling is mechanistically the same. Let's break it down. When we put these two primary pathologies head-to-head, the real game-changer, the critical differentiator, is the status of our blood-brain barrier. In cytotoxic edema, the BBB stays tightly closed, and because it's closed, there's zero protein extravasation, meaning no leakage. Therefore, you won't see any enhancement on a CT or MRI.
At the cellular level, the cells themselves actually swell up and then eventually shrink. We typically see this classic cell death pattern following head trauma or a stroke. Vasogenic edema, though, it's the exact opposite. The BBB is disrupted, serum proteins literally leak out of the vascular system, which is precisely why this type of edema beautifully enhances on imaging. In this scenario, the cells remain stable, but the extracellular space around them massively expands as fluid pools. And here is a huge clinical takeaway. Because the BBB is open and leaking in vasogenic edema, it responds incredibly well to corticosteroids like dexamethasone. That is exactly why steroids are prescribed for the swelling surrounding, say, a metastatic brain tumor.
Of course, physiology rarely stays neatly inside two separate boxes, right? So we have to talk about a particularly dangerous hybrid state, ischemia-related edema. This is a complex mix of both cytotoxic and vasogenic processes. Initially, the BBB is closed, and the extracellular space shrinks. But later on, the BBB bursts open. Fluid finally leaks out, and the extracellular space rapidly expands. This delayed fluid shift is super dangerous and is very often the sneaky mechanism behind a patient's delayed deterioration following an intracerebral hemorrhage.
All right, we've mapped the brain's physical and chemical architecture. Now let's pivot to something entirely different for Section 4, localizing language and speech. We're getting into functional cognitive mapping here. Just like we did with the barrier neurophysiology, we're going to extract every single functional and anatomical rule from this content. We want to make absolutely sure you understand exactly how human beings process and generate language, without skipping a single detail.
But before we dive into the textbook maps, we really have to address a massive clinical caveat. Ready? Language function cannot be reliably localized on anatomic grounds alone due to individual variability. In real life, everyone's brain is wired just a little bit differently, and this represents incredibly high clinical stakes. If a neurosurgeon is performing a maximal brain resection, like removing a tumor, they can't just look at the anatomy to avoid destroying the patient's speech. This is exactly why awake, intraoperative brain mapping is absolutely mandatory. They literally have to test the patient's language live, in real time, to minimize the risk of causing aphasia.
Keeping that vital caveat in mind, let's move to Section 5, the classic language model, focusing specifically on the dominant hemisphere.
This classic model is essentially built on two primary pillars that communicate with one another. First up, we have Wernicke's area, which is localized roughly to Brodmann area 40 and a part of 39. This is your center for language understanding. If a patient gets a lesion here, they develop what's called receptive aphasia. They can't understand language, but they might still actually produce speech. However, it's a fluent aphasia, meaning they'll just generate a flow of words that are completely devoid of any actual meaning or content. Word salad, basically. A set head-to-head against that is Broca's area. Localized to Brodmann area 44, this is the motor speech area. A lesion here causes expressive aphasia. These patients perfectly comprehend what you're saying to them. They know exactly what they want to say back, but they completely lack the physical, motor ability to generate the words to reply. Now you might be wondering, how do these two distinct areas even talk to each other? Well, through a bundle of fibers called the arcuate fasciculus. If that specific connection gets damaged, the patient suffers from what we call conduction aphasia.
And that brings us to our final part, Section 6, the dual stream model, which officially brings our understanding into the modern era.
Because let's face it, modern neuroscience has evolved dramatically. We no longer look at the brain as just a couple of isolated, simple anatomical zones connected by one single wire. Instead, modern neurology understands language as these incredibly complex, parallel flowing streams of data that are communicating across multiple regions simultaneously.
Let's walk through the step-by-step functional flow of this dual stream model. Everything kicks off with Step 1. Initial processing of language happens in Region 1, which consists of the primary auditory areas. From there, the data splits into two entirely distinct streams. Step 2 is the ventral stream. This flows from Region 1 down into Region 2, the anterior and middle temporal lobe. Think of this stream as being responsible for the what of language, speech recognition and accessing lexical concepts. Then we have Step 3, the dorsal stream. This pathway takes that phonological information and maps it directly onto your motor areas to help you physically produce the sounds.
So you might be thinking, what happens to the classic model in this new framework? Well, it actually gets seamlessly integrated right into the dorsal stream. As the dorsal stream maps sound to physical movement, it relies heavily on Region 3, which roughly corresponds to the old Wernicke's area. It also flows through Region 4, the premotor cortex, and Region 5, which is roughly Broca's area. All three of these regions, Regions 3, 4, and 5, are highly involved in working together simultaneously in dorsal stream processing.
It's this beautifully intricate, interconnected loop rather than just two isolated islands.
Well, there you have it. You've now mastered everything from the microscopic tight junctions of the blood-brain barrier all the way up to the complex dual streams of functional language mapping. And we did it by skipping absolutely 0 essential points, so you can officially close that textbook. But as our models continue to evolve from those simple anatomical zones of the past into the complex, flowing networks we understand today, it really makes you wonder, with awake mapping and ever-improving MRI technology, what hidden complex functional networks will tomorrow's advanced imaging reveal next? Keep that curiosity alive and keep exploring the incredible architecture of the brain.